Good morning. How is everyone today? Great. Well, I think it's time to get started. My name is Mary Bradley. I'm the Director for Healthcare here at Army Residence Community. I help oversee the skilled nursing facility, the assisted livings at Crestway and Lakeside, and we'd like to welcome you today to focus on healthcare talk. We're going to zero in about some differences between hospital care and SNF, skilled nursing facility. When you see the acronym SNF, skilled nursing facility, we're going to dive a little bit deeper into that. And we have several of our knowledgeable team here today that's going to present a little bit in those areas. I'll start by giving an overview and they'll go into that a little bit further. But first we'll have each one stand up, introduce themselves, say who they are, how long they've been with the ARC. So we'll start with Diana.
Hi, I'm Diana Lorenzo and I work in healthcare doing admissions.
Oh, sorry. Would help if I gave you the mic.
Diana Lorenzo again. I do admissions in the healthcare center, and I've been at the Heart for 9 years.
Good morning. I am Deborah Settles, and I'm the social worker in the healthcare office, and I've been here about 4.5 years.
Good morning. My name is Arlena. I'm the registered dietitian, and I've been at the ARC for 6 years.
I'm Jonathan Steiner. I'm in charge of the therapy department, and I've been here 24 years. I had hair when I started.
Good morning, my name is Kathleen. I'm your wound care nurse and your QA nurse as well. QA. Oh, I've been here for 6 years.
Okay, thank you. I appreciate that. Just want to hang on to that. Okay, so we'll get started. I'll give a little bit of an overview and then each of our team members will go into that a little further and we'll have question and answer at the end. Okay. Let's see. Okay, so when we talk about hospital care and skilled nursing care, the key words are acute care and then long-term care, more so the skilled nursing piece for rehabilitation, but the focus generally is managing long-term. So for hospital acute care, hospitals do provide immediate intensive treatment for serious illnesses and emergencies requiring urgent medical attention. The skilled nursing facilities offer post-acute care, rehab, long-term care support for medically stable patients. Stable is a key word there for skilled nursing. The difference is also in care intensity. Hospitals focus on urgent care, while SNFs emphasize recovery and daily living assistance over time. Daily living assistance talks about, you hear the term sometimes ADLs, activities of daily living. Those are things such as bathing, dressing, and grooming. Hospital medical services provide, of course, emergency care, surgeries, diagnostic imaging, intensive care, specialized medical teams, and daily physician oversight. In the skilled nursing facility, we offer physical, occupational, speech therapy, medication management, and again, assistance with activities of daily living, which is short for, what's the acronym? ADL, thank you. So focusing on differences, hospitals again handle the complex medical interventions, while SNFs emphasize rehab, rehabilitation, and improving patients' functional ability and their quality of life. Staffing. Hospital medical staff. Hospitals, of course, have physicians, surgeons, nurse practitioners, physician assistants, and specialists for continuous advanced care. In the skilled nursing, we have personnel such as registered nurses, licensed practical nurses or LVNs, certified nursing assistant, and therapists for patient support. Physician availability in the SNF. And this is key, that physicians are available but typically do not provide daily site presence, but they focus on routine supervision, and they are in contact with our nursing staff pretty much day to day, but they make rounds on a set schedule. And as we get toward the end with Kathleen's part, we'll talk a little more about the physician role and the nursing role. In long-term care, again, the support focus is rehab, emphasizing that medical supervision and personal assistance. Of course, the complexity of care is important. Hospitals, again, deliver that high intensity for critical situations using advanced technology. specialized emergency care, performing complex procedures with specialized teams. For the SNF, we provide lower intensity care, focusing again on recovery, rehabilitation for chronic conditions, chronic and stable conditions. Short-term hospital stays focus on stability. Longer stays in skilled nursing focus on extended care. Sometimes it can be a few weeks, sometimes it can be several months. It depends on the ability of that person to progress. And of course, John Steiner will talk more about that. Hospital cost factors. Hospitals do have higher costs due to the intensive care, the specialized staff, and the advanced medical equipment. In the skilled nursing arena, we try to operate, of course, as efficiently as possible, offering cost-effective care for patients not needing acute care. The SNF costs will vary based on the service type, the duration, providing affordable long-term or rehabilitative care. Insurance. Hospital coverage is paid by Medicare Part A, TRICARE, private insurance plans with possible deductibles and copays. In the skilled nursing area, that's also covered by Medicare, up to possibly 100 days based on your progress and ability to perform, including TRICARE. And TRICARE, you have to have authorizations for that, and of course, private insurance eligibility. It's very important that we learn individually about the nuances critical for care planning and managing those healthcare expenses. And we're glad to help answer any questions on that section. Patient demographics. Of course, hospitals cater to folks of all ages with a variety of medical conditions requiring intermediate care, while skilled nursing focuses on our seniors and works on recovering for strokes, chronic illnesses, and again, focusing on that ongoing rehabilitative need. Staffing ratio. Hospital ICU staff does focus more on, say, a 1-4, 1-6 patient ratio, looking at that high care need. For generalized nursing in a hospital, you'll have a little bit lower ratio, but they still keep very close monitoring. In skilled nursing facility, we do have a lower ratio, but we do have RN coverage, RN staff coverage daily, with one nurse overseeing many patients, but supported by a team of certified nurses aides and other folks. Patient outcomes. Hospitals focus on stability, survival, achieving high recovery rates from acute condition, where skilled nursings do focus on that support for your functional abilities and quality of life. The outcome goals for a SNF vary, but they focus on enabling patients to return to home or transition to less intensive care. And with that, we're going to now turn it to Diana Lorenzo, our admissions liaison, to talk about her role in the admission process for healthcare.
Okay, good morning. So once you go to the hospital, I get a notification or email from the front desk, and we have a list of residents that have been going out either that day, the night before. When I come in the morning, I review my emails to see what patients did go out to the hospital. I contact the case managers. I contact either Northeast Methodist, Banzi, Northeast Baptist, Central Baptist. I do keep in contact with the different case managers, and I work with them directly to get, so our clinicals, we do, so the first thing is I gotta verify that you have your 3 midnight stays. So Medicare will cover your stay here in healthcare. I verify your eligibility, either via Medicare or TRICARE, depends what you're gonna be using. If you exceeded your 100 days and you're out in the hospital trying to come long-term TRICARE, I also run eligibility on TRICARE. The next step is I request clinicals from the case manager, and clinicals is like your H&P, any SNF orders, therapy evaluations, all that's included in the clinicals. The next thing I do is upload clinicals onto your matrix profile, and then I notify our IDT team. They review your clinicals to see if there's anything specific that we need, different like oxygen and stuff like that. If we need anything to order, like the team will review that. And once that is reviewed and you have completed your 3 midnight stay and the hospital says you are ready to discharge, they will contact me and I will give them what we call is MOT, is a mode of transport. I give them your room number, the administrator's information, the physician's information. I also give them the nurse's number, so they call and give report. Each nurse gives report from the hospital to the SNF, and they schedule your transport. I give them the room number. Either we use Acadian or Apollo for transport in the SNF, and then we just wait for you guys to return here to healthcare, and we'll move on from there. I will transfer over to Deborah Settles.
Hello, everyone. Your process with me starts when you arrive into healthcare. Wrong way. Sorry. There we go. The first thing that I am going to do when you arrive into healthcare is I'm going to verify your code status. And you're either a full code, meaning that if you should have an emergency, if your heart should stop, if you the staff walks in the room and you're non-responsive, a full code, they will do everything they can to save your life. CPR, call an ambulance, all of life safety measures. Or you're either a do not resuscitate, which means that the staff is aware that you are a do not resuscitate and they're going to let nature take its course. I have to verify that as soon as you get there, and I want you to keep in mind that an advance directive is not a do not resuscitate. You have to have an actual do not resuscitate form on file in our healthcare. If, and this happens a lot, family members arrive and they say, I know that we have a do not resuscitate, it's at home or it's somewhere, I need to look for it. I will explain to you at that point that you're going to be a full code until I actually have that form in my hand and verify that all the signatures and everything are in the right place. Once I do that, I can change your code status to a do not resuscitate, but it won't be done until we actually have the form in our facility where we can lay eyes on it and verify that it is completed accurately. And then the next step after that, a couple of days later, I will come back and talk with you, talk with the family. We have an admissions packet that has to be signed. It's a lot of paperwork. It's the packet that I have is 10 signatures, and I know that everyone says, I've signed so much stuff already. You're signing consents to treat from nursing, and that happens as soon as you arrive. My admissions packet is separate from that. So I give you a couple of days, try to give you a little bit of time to settle in and then bring the admissions packet in there. We can talk about it, go over it, you can review it. It's very time consuming, so that takes a little bit. And then the next thing that I may have help you with is your laundry services. You have 3 options when you come into healthcare for laundry services. The family members can choose to do that for you. We have what we call a communal barrel down each hallway where all of your laundry is in one barrel that goes to housekeeping, and they do that all together. Or if you choose an individual laundry, that laundry is $25 per load, and then I step in with that and go downstairs and physically schedule that with housekeeping and come back and let you know what day of the week they're going to come and pick up your things. Specifically, they bring a basket for you, put it in your room, they come and get that, do that laundry, and bring it right back to you. So those are things that I will take care of as well. And then once you've been there for about a week, give or take 10 days or so, depending on how things are going, we will schedule your first care plan meeting. And this meeting can be done in your room, if that is your preference. We can have it in the conference room with your family members. We can do a conference call with family members. Arlie. Wait. We can, yep. As long as it's out.
What moment?
Yep. It's odd. Okay, and once we come to you, we're gonna schedule a care plan with you, and we're gonna call your family members who you want there to be a part of the care plan. And at that first initial care plan, we're gonna talk about where you are in the process. We're gonna answer any questions that you might have about what's coming, how long you might be staying, and John will explain this a little bit more. We go over therapy and how that's going and how you're progressing, and anything that we need to discuss is discussed at this care plan. All of the team is there. Arlie is there for dietary, John is there for rehab, I am in there, nursing is in there. activities is in there. So we are all in one place at one time and can address all of the issues at one time. And then another part that I am responsible for is to complete assessments. When you come into healthcare, Medicare requires us to do assessments. We'll do an initial assessment when you arrive, and then depending on your schedule, it's David who does our MDS schedule, but those are the assessments that we have to do, letting Medicare know how you're progressing, things are changing and things like that. And then once you've gone through the stay and you're progressing and we're talking about discharge now, another care plan will come up. We'll plan your discharge going home. Again, the whole team will be in there, and we will work out the details of you to go home. And this all depends on if you live in the high rise or the cottage, or if you're, sometimes we have direct admits, but all of the discharges are different. We talk about outpatient therapy, we talk about home health as an option. This is where we discuss any equipment you might need, wheelchairs, walkers, hospital beds, anything, oxygen, nebulizers. It just depends on what you need going home. And then I'll order that. I'll order whatever equipment you need. I'll take care of all of that. I try to get it all delivered to healthcare before you leave, but sometimes the equipment is delivered to your home, depending on what it is and things like that. And the last thing that I did want to mention, and I just want to give you this information so that you're aware, sometimes I get phone calls from case managers or even residents, just saying, so my husband, my wife are in the hospital and they're coming to healthcare, so they're, trying to make arrangements with me. I will always refer you back to Diana. Healthcare has worked really hard to streamline our admission process and to lessen the confusion and all of the other things that go with talking to our team. We have streamlined it so that all of our admissions, no matter what hospital or anything like that, goes through Diana. So it's not that I don't want to talk with you or don't want to give you information, but in order to try to avoid confusion, I will always direct you back to Diana so that we can have, and she ultimately gives the information back to us, but she is the central person for admissions and the intake and all of the things that go with that. And then, yeah. Oh, did you finish? You got done?
I'm done. Well, I'm next. Okay. So I recently actually had the opportunity to speak at a town hall. So you may be very familiar with the community living dietitian. We do hold a very dynamic role. So I'm going to quickly review both of those roles, the clinical focus and food service management. And I did want to take the opportunity to compare acute care and post-acute, which is our long-term healthcare setting. A lot of the information that you see on this chart was actually covered already, but our primary focus are patient resident population, so it is the older adult, often with dementia, stroke, CHF, diabetes, or Parkinson's, or related conditions. Our nutrition goals in the hospital setting, those are often rapid assessments. They may be doing tube feeding protocols, TPN, and therapeutic diets for acute issues. For our nutrition goals as the long-term care dietitian, that's often revolved around weight maintenance, pressure injury protocol and prevention. We do work closely with a speech language pathologist for dysphagia, and then with the team for end-of-life care. Our workflow in the hospital setting may include daily medical rounds, fast charting, and frequent diet changes. For the long-term care dietitian, we do complete assessments monthly, quarterly, or if we have a significant status change. We get ready for survey readiness as the team and staff training. For operations and oversight, so this is more of that food service management role. I actually know many of you, so my process here does start in healthcare, almost like Deborah had mentioned, but I am familiar with you with my food service management role within independent living. But we work closely with our interdisciplinary team. So in the hospital setting, the care staff would be physicians, nurses, pharmacists, OT, PT, and speech. We do have similar roles here, but it's actually our nursing staff that run healthcare. They are our on-care staff. Speech therapy activities, social services, and families play a large part in your care. Our regulatory body for long-term care is CMS. We do follow CMS protocols and guidelines and MDS documentation. The dietitian in the long-term care community does oversee the kitchen and staff, often in a nutrition care management role. So we oversee often satellite kitchens. We build menus. This is your home, this is your menu. We have the opportunity to actually liberalize diets a little bit more so because of our clinical goal of maintaining your weight. The pace and schedule, I actually find this the most meaningful part of working in long-term care. We get to build relationships and establish rapport with all of our residents. The hospital setting, the dietitian may see maybe 20 new admissions a day, and it's very fast-paced. I love our setting. We are here for a longer period of time for you to heal, meet your goals in rehab, but I get to sit down, we have a conversation with your comprehensive assessment to build patterns and understanding of your individual nutrition needs. And I love that part. That's my favorite part of long-term care. We do hold unique skills. So of course it is our population of the older adults, so geriatric nutrition, dementia-related feeding, so assistance with feeding. We work a lot with texture modified diets, so IDSI standards. And you've probably seen some of the fun puree plates that we've done before. And I'm gonna wrangle John up here.
Okay, there we go. I like to walk around. I like to walk around when I talk. So I'm glad we're having this because I think it's important you guys understand the difference between some of the levels. I'll use the word levels of care, but really it's more, what does therapy look like in the hospital? And I've thrown in the acute care hospital. I've also added kind of a section for what I call a rehab hospital, which would be like Warm Springs, and then what therapy is like here, because they're all different. And if you're kind of coming in and you're expecting one thing and you don't get it, I want you all to have realistic expectations and understand, the different levels of care, because that's really what it's all about. So you go into the acute care hospital, everything there is really fast. I mean, the therapy there is very, very focused, and it's based upon your immediate needs. They're trying to make you stable, okay? The majority of the residents that come here after an acute care stay at the hospital, I was asking, did they get you up over there? And the usual response is either no or one time, okay? They just, they're not doing any kind of intense rehab. They're just getting you there, getting you ready to either go home or go to the next step. Okay, an example that I had personally years and years ago, I was in a motorcycle wreck. I hit by a car, got to the hospital, had a broken leg, separated shoulder. Therapist came in. That's actually how I got into therapy. He basically, here's one crutch, here's a sling. Oh, you need to do stairs? Okay. They watched me go up and down the stairs. Okay, that's it. That's all they gave me. That's it. So it's not a lot. Okay? And I think the big thing that I see here is when they've been lying in bed, you're in the hospital for 3 days, 5 days, whatever, and you don't get up. When you get to the rehab hospital or here, you're not only dealing with the illness that you had, but you're dealing with the weakness of having been in bed and not moved at all in the acute care hospital. Okay? So it's not really, really intense therapy. That's what I want you to get out of that long spiel. And of course in the hospital, your doctors are there daily. They're gonna come see you every day, okay? So the next one is gonna be the rehab. Okay, this would be like Warm Springs, okay? This is much more intense therapy, okay? They're generally rehab versus here at Warm Springs, generally, the patients are gonna be more acute, okay? They're gonna need more medical attention than you would here at a SNF, okay? The therapy is much more intense. Generally, you're gonna get about 3 hours a day, more or less, okay? The physician is there all the time, okay? Again, because in theory, you're more acute. You need the more medical attention. Now, generally, most of these folks, when you go into the rehab hospital, they're expecting you to recover much faster. And by much faster, I mean it's compared to going to a SNF or coming here. So you see a lot of post-op, knees, hips, those type of things. Okay, where they're expecting you in 5 days, 7 days, 10 days to be much better and able to go home. And if you do go to rehab, I want you to remember this, they're gonna push you to go home. They want you to go home. They get financially dinged if you don't go home and you go to a SNF. But you have the right to go wherever you wanna go. So if you don't think you're ready to go home, you say, no, I wanna go to the ARC SNF. Okay, so you have that right, okay? So moving on to here, again, so this is a skilled nursing facility. Generally, when you're here, your stay is probably going to be longer than, say, in an acute care rehab. Again, probably because it's going to take you longer to get better. You may have more things going on. There's most people who come in here have more than one thing wrong with them. Okay, therapy-wise, it's very individual as to how much therapy you're going to get. A lot of it's going to be based on what you can tolerate. Okay, we don't have this set. Oh, you have to have 3 hours of therapy a day. It's not like that. Now, a lot of times, if you're on PT, OT, and speech, you're going to get 3 hours a day. If you're needing all of that, and you can tolerate it. Most of the people here probably get closer to 2.5 hours a day. It just depends, again, it's very individualized, what can you tolerate. Generally, again, the therapy is probably less intense than, say, rehab is, again, because you're not able to tolerate as much, all right? Here, and this is another question that I get asked all the time, family members, patients, I don't know why, but they expect the doctor to be here every day. The doctor is not here every day. If you need a doctor every day, then you need to be in a different facility, okay? Generally, if you're here, you're considered to be, what I'm gonna use the word, medically stable. If you're not medically stable, then we need to ship you to a different place, okay? So that's kind of the difference, okay? So if you have any questions, and when we get done, feel free, we'll all be here. I'm gonna turn it over to Kathleen now.
Alright, I just want to talk about the nursing in hospital versus SNF. I want to walk you through how is it in SNF in nursing lens compared to hospital. At the hospital, you do acute care. The goal is to stabilize patients in events of sudden illness, injury, surgery, or emergencies. For example, you had a fall at home, you broke your hip, that's acute event, and you had to go to the hospital. You had a bad infection and you got to go to the hospital. What happens then is after they stabilize you, you got your IV antibiotics, they put you on oxygen, they did your surgery, you're stable enough, you can't stay at the hospital because, well, you're stable, then they can't send you home because you're not stable enough and not safe enough to be at home. That's where we come in. It's like a bridge from hospital to home. We do post-acute care. We focus on recovery, rehabilitation, and preventions of complications. One example for that is you have a pneumonia, you are on antibiotics, IV antibiotics. We can continue the IV antibiotics at SNF. Our nurses are trained to do that. We do preventions of complications, like for you going back to the hospital, we monitor your labs, we do assessments every day. That way, we can prevent any issues that arises before it becomes an emergency. And for the length of stay, usually hospitals are short-term until the acute problem is stabilized. Most of the time, our residents, majority are stay at the hospital 3 nights to 7 days, 2 weeks. The difference for SNF, you stay here longer. It ranges from weeks to months or to permanent residence. Because it's longer because it takes time to recover. We focus on steady, stable progress. For the level of care, at the hospital, we have higher acuity, low volume patients. And, Arlie? Okay, so for nursing, we have lower acuity, which means you are clinically stable. That means we also have higher volume of residents. Example is in ICU. Usually, as a nurse, we have 1 to 2 patients. And that's the maximum. 2 is pushing it already. And for like the med-surg, 5 to 6. So we have higher volume of residents in SNF setting. The next one is because you are unstable or acute, they require sometimes continuous cardiac and vital signs monitoring. They do titrating IV drips, arterial lines, which we don't do in SNF care. At SNF care, we do daily nursing care, like medication management. We give your medications, oral IVs. We do wound care and hydration. Okay. Also, the settings are different, and there's different units. At the hospital, you have your ICU. You have your post-anesthesia care unit. You have your progressive care unit, which is your step-down ICU. You have telemetry, you have med-surg. There's a lot of units there I didn't mention because it doesn't apply. In nursing homes or SNF, we have hospice care, which means you have like a terminal illness and it's expected for you to pass like in 6 months. Usually that's one of the criteria for hospice care. We have respite care. It just means that it's for a short-term period. Somebody's gonna go away, a family member, and you don't have somebody at home to take care of you. Just give us a call and we'll arrange a room for you. You can stay here. The amount of time is something that you have to discuss with Diana. We also have memory care, which is our OAKS. It's a secure unit. We are able to monitor them, are like people with Alzheimer's and dementia and cognitive issues. It's one way of keeping them safe. We also offer long-term care and skilled nursing care. Skilled nursing care is like when you come from the hospital and we do your rehab, therapy, and continuity of care from the hospital. The difference also for the nursing is one is the staffing, as I mentioned, like high nurse to patient ratio at the hospital because they're more acute. And usually it's 12-hour shifts. And it's also a revolving door. You get different nurses every day. There's no retention. They don't remember the names sometimes. But for SNF, we have the RNs, LVNs, CNA, medication aides, hospitality aides. We have lower nurse to patient ratios compared to the hospital, but we do have retentions. As much as possible, we try our best to keep the same nurse to the same unit for the same resident, because we wanted to establish routine. This is your home. We wanna establish relationship and rapport with you. We wanna know your preferences and routine. Next one. This service is provided, mentioned earlier, at the hospital. They do continuous cardiac and vital signs monitoring. We don't do that here at SNF. If you need your blood pressure taken every hour, that would mean you are not clinically stable. They also do IV trips, and they have emergency response or the rapid response team in events of codes. Nurses usually at the hospital are trained for advanced care life support. Also lab and advanced imaging on site. Also they have physicians and specialists on site. The difference is we do offer a lot of those as well, but in a different way. We do medication passes scheduled, and vital signs are scheduled and not continuous. We do check them every shift, and let's say there's been a change of your condition. We do continue IV antibiotics and hydration. We can start IV here. We can start you in fluids if you're not drinking enough. That way we don't have to send you to the hospital just to get an IV because you're dehydrated. We can start IV antibiotics here as well. One thing here that wasn't mentioned is also we manage tubings, like PEG tubes. If you come out of the hospital with a drain, we also manage that. We do observation and early detection of decline. So we do have nurses every shift. We check your vital signs, do an assessment. We try to catch anything before it becomes an issue to prevent you from going back to the hospital. We try to prevent emergencies. In lieu of emergency response and codes and rapid response, they do it at the hospital. Our nurses are trained for basic life support. Majority of us, or all of us have CPR training. And in the event of that emergency, we have to send you to the hospital. The difference about the lab draws in the hospital is they have on-site, whereas we have a contract with another company. We do lab draws and then it's sent out. We usually do lab draws weekly. Compared to the hospital, they do frequent lab draws. They do it daily, sometimes every 6 hours if your electrolytes is out of whack. We do x-rays as well, but they are mobile, and ultrasounds. As far as advanced imaging, like CT scans and MRIs, we don't have it here. We don't have it mobile. So we have to schedule an appointment to imaging centers. But usually that takes like the next day or within this week. And for the physicians, at the hospital, they have it on site and specialist on site. For the SNF, we have Dr. Soria. He visits every Tuesday, see our skilled residents. And if you needed a specialist, we can refer you and we'll just schedule an appointment. Also, even if Dr. Soria is not on site, our nurses are trained to assess, look for signs, and communicate to Dr. Soria if there's any issues. That way we can address them and not wait for him till Tuesday to get your issues addressed. We address it here and there. Okay, and as far as nursing, the goals, nursing is to stabilize and treat acute issues until you're stable. That means like your blood pressure is good, your respirations are good, your infection is stable. But in SNF, our goal is for you to regain independence, prevent rehospitalization, improve your quality of life and safety. And that concludes our presentation. We welcome any thoughts and questions that would help a lot of people here in the room.
Thank you, Kathleen. Appreciate that.
They didn't do this.
If we have questions.
They usually do.
First.
Good morning. My question is for Diana first and then Deborah, social work. Diana, what happens on a weekend? If we come in on a weekend, is there coverage?
Yes, there is. I'm actually on call. I have a cell phone. So I actually have a cell phone and I'm on call 24/7. I do answer phone calls even late at night. And if I don't answer, I'll give you a call back as soon as possible.
Thank you. And social work, I'm a single person. All of my family members live in Maryland and California. Do you do consultation over the phone or Facebook or whatever in terms of making care plans?
Absolutely. We can reach out to your family anywhere that they are, and schedule a care plan with them when it's convenient for both of us to meet, but yes, those can be done, over the phone. Yes.
Other questions?
Yes, since you're here, go ahead, then I'll go over.
Are 3 midnight stays required in order for insurance to pay for Warm Springs?
No.
No.
But it does, if you go to Warm Springs, generally that gives you the three. When you go to Warm Springs, that gives you the 3-day hospital stay to qualify to come here under Medicare. So we have certainly used Warm Springs in the past for someone who, for whatever reason, they did not have their 3-day hospital stay, but we felt that they would benefit from skilled therapy. We would send them to Warm Springs, they would stay there for however long, and then they, again, could come back here covered by Medicare and TRICARE.
Start this row and then.
October 16th, I'm going to be having surgery, and they said that I would be staying in the hospital for 3 days. From there, I'm going to be transported to Warm Springs, and then from Warm Springs to here. Have you ever heard of that? Is that possible?
Yes.
Yes, but it depends on how you're doing at Warm Springs. When you go to Warm Springs, their intent's gonna be to send you back to independent living. Okay?
I'm having extensive foot surgery,
Yeah.
I won't be able to walk for 12 weeks.
Then you need to tell them for sure that you want to come back here if you feel like you need
Yeah,
it.
they know.
Okay, so, but yes, that does have, it is not unusual for them to go to Warm Springs first, especially, again, if they're still acute. They need things that we can't do here. They are acute care hospital, we're just a rehab hospital. So they, have the doctor on staff, they can do labs, they can do all these things that we can't do here, because that's not what we do. We're a different type of facility.
Okay, thank you.
Work our way back.
My question is, my wife is on dialysis. She does it Monday, Wednesday, and Friday in the afternoon. I'm not sure the ARC is aware of that. Should I notify somebody here?
Yes. Yes, you should, you could speak to resident services so they could have that information on file. Should a medical emergency occur, they need that information.
Okay, over this side.
Two questions, only one of them is quick though. Am I correct that you manage PEG tubes? Am I correct that you do not manage tracheostomies? Or do you?
Our nurses are trained too, as well. For me, I am trained for tracheostomy, but as far as ventilators, we don't have it right now. But tracheostomy, it's something we have to discuss if it's something we are capable of right now, because it does require monitoring of your oxygen as well.
Okay, yeah, so a plugged tracheostomy might have a chance, but it depends on the evaluation. The other thing is about DNR. I participated in that as part of an ethics committee for years. And you, as presented here, it's black or white. And my experience, you either is or you ain't. Okay, but my experience was that it was far more nuanced than that and often involved members of the family, and it changed due to changes in circumstances progressively. Is that an ongoing discussion that can be undertaken with the family?
Yes, we do have meetings with the care plans, during the care plans with family members for specific instructions, and our director of nursing, Faye, is part of those meetings. But generally in healthcare, in a SNF setting, you are either a full code to receive life-saving treatments, or you are a DNR. And if you want something specific, like a patient does have the right to say, I don't want to be sent to the hospital. I don't want certain things, part of their care, whatever they're deciding that is. Those conversations are held with nursing, with Faye, so that she understands the wishes of the patient and of the family. And of course, they are respected, and we figure out how to work those into the plan of care for that specific resident.
And for those with speech or cognition problems, you do use the family as...
Absolutely.
Okay.
Yes, absolutely.
Thank you.
Thank you, Deborah. Okay.
I'm confused about all the coverage. If I'm in rehab and I used up all my days and I said, no, I'm not ready, and I come here, do I get any coverage or is it out of pocket?
Well, so when you come into the SNF, you're initially here under Medicare. And generally speaking, most of the residents come in with 100 days of coverage from Medicare.
But what if I used them in rehab at Warm Springs?
It doesn't count towards that. Warm Springs is a higher acute level of care, and those Medicare days do not apply at Warm Springs. The 100 days are for the skilled nursing facility. So you would arrive to us with 100 days if you have not used them in another SNF previous to arriving to us. And where our residents are different is that most all of us have TRICARE. So if, for example, you were at a different SNF and skilled nursing facility and you used just 30 days. So you got here with 70 days left on your Medicare, and you still needed care, you still needed therapy and nursing care after those 70 days. We can transition you over to TRICARE. We all of you who have TRICARE have the ability to transition over to TRICARE and continue services through TRICARE after that.
How many days?
TRICARE is unusual and wonderful in its own way. We have to submit an authorization when your Medicare days are expired, and John and David submit those authorizations. They will approve the authorization for 30 days at a time, but TRICARE has no limit. So as long as you are progressing, as long as you are participating, John and David will continue to put in those 30 days, and it could go on for months, just depending on your progress and where you're at in your therapy.
And we need the 3 hospital nights before we come here?
Yes, before you come into the skilled nursing facility, you have to have 3 midnights. And Warm Springs count as the 3 midnights if that is where you are. If you didn't get it at the hospital stay, and say you were at the hospital for 1 night or 2 nights and then they sent you to Warm Springs, you can stay at Warm Springs for 3 midnights and then you can come here.
And can I come here without being in the hospital?
It does change things. You come into to healthcare as a long-term resident, and that would be private pay. We need the 3 midnights to utilize your Medicare insurance.
Good questions. I appreciate all of this. And like you said, admitted, not observation, right? You have to
Correct. You
actually
actually-
admitted for the 3 midnights.
Actual 3 midnight stays in a hospital.
Okay, others? Questions? Yes.
One of my friends is getting a knee operation, and that's gonna be on Monday. But, yesterday, the doctor, orthopedic doctor, had a whole pile of equipment delivered to her apartment. Doesn't our physical therapy have all that stuff?
Yeah. No. First of all, every doctor is different. Every doctor has their own protocol. So we have to follow whatever they say that they want. What the equipment you're probably talking about is like what's called a CPM unit, I would assume. Some of those some doctors use them, most of them don't use them. And so usually that equipment's brought in by some, durable medical equipment company, and they're rented, and then as soon as they're done with them, then they take them back. We have a lot of equipment, but something like that specifically dealt with post-op, we don't have it.
Anybody else? Oh, okay, moving to the back.
Can Diana go through a little bit of the description of how you'd handle a hospice transition and working with Lucy, and how that works together between healthcare and independent living?
So we have what we call a healthcare. It's like a sheet that they monitor every day. The front desk workers put on their so and so went out to the hospital today. They're gonna be staying in the hospital. So what I do the next morning is I call the hospital and reach out to a case manager. If you're already admitted, you should have a case manager. I call the case manager and I let them know, is this patient going to be staying for 3 nights? Are they going to be needing SNF? If they say you are needing SNF, I will tell them, okay, this is my fax number. Send me any clinicals, any progress notes that we need so we have all the information. With Lucy, I usually just talk to her when it's a respite stay. If residents are going to be needing a respite, she calls me and sends me some information that they do have, like HMPs.
I don't think my question is precise. I'm talking about hospitalist, the hospitalist program. You want to go into a hospice.
Hospice. So hospice is Deborah.
Are you asking how to get hospice?
Just the communications that take place between you and Lucy and independent living and skilled care. How does that progress for hospice?
For hospice.
If an independent resident needs hospice, that's something that Lucy works with individually with them. I usually don't have anything to do with that. Lucy has a company that she uses and utilizes for hospice should an independent resident need that. My role is only if they come into healthcare. That is when I, take part in that situation.
Do you facilitate the movement over to independent living if that's with Lucy, if that's the case?
That goes back to Diana. If the resident, just say an independent living resident is on hospice and now they have declined and they need to come into healthcare, then that's when they would reach out to Diana, and that's considered another admission. So she would work the process for them to come into healthcare.
I wanted to make one small note to everybody regarding the interaction between independent living and healthcare. Every single day we have a stand-up meeting in healthcare, and we review who has gone out to the hospital for an admission, who's being discharged, other residents that might be on our radar that have up-and-coming procedures that have come into resident services or have advised Lucy about. It's a very collaborative effort in so many ways. I'm on the phone in the evenings with case management, with all the local hospitals for independent living admissions, as well as Diana. So we know typically who's coming and going. But if you don't tell us that you're going out to have a procedure, we're typically notified by a case manager at a local hospital that Mrs. Smith has now received a hip replacement, and the next morning in the stand-up meeting, that discussion takes place. So we want to make sure that you have your 3 overnight stays, for instance, and if not, are you going to Warm Springs or to Pam down on Randolph Boulevard, so that we can bring you back to SNF to have therapy here. Lucy is a direct conduit in so many ways. So if you know that you have a procedure up and coming, please advise her. Please come into resident services. Let us know. The same holds true for respite situations. Some of you that are caregivers for your spouses need to get off the corner, go visit family, and in doing so, we provide that assistance, and we're in touch with Faye immediately, with Deborah, with the interdisciplinary team, so that we make sure that a room is available for your spouse to come and visit while you're away. It's very important that you keep in touch with us. The front desk does an exemplary job of making sure that you are on our list at a local hospital, and we know what the movement is going to be. Every day we get that email that will say you are in Northeast Methodist, Northeast Baptist, Stone Oak, you're at BAMC. So we know how to follow you throughout the system and then bring you either back here for your recovery, or Lucy can follow you back in independent living. And that's very important, because we need to know if you're having home health, if you need oxygen, or any other ancillary service. So we follow you literally from A to Z. And that's important for a positive outcome in your recovery. But I just wanted to make mention that Diana is very critical in the process in following you, as well as the front desk and Lucy. So don't be shy. Make sure that you tell us that you're having a procedure or something's going on. That way we keep you on our radar, and we can be in touch with case management at any given time. Thank you.
Thanks, Debbie. I think if they forget, we can also use the Apple AirTag, right, on the shoelace? No? Okay. But thank you, appreciate that. Any other questions? Yes?
This isn't a question, but it's a comment following up on this 3-day rule. It's very important if you go to the ER, for example, emergency room, and you're there for observation, you may be there for 8, 9, 10 hours. My wife spent 21 hours in Northeast Methodist 2 years ago in the ER before they admitted her to a hospital room. So that 3-day window didn't start ticking until she left the ER and was in a hospital bed. So make sure you calculate that 3 days correctly, or else you're going to be paying out of pocket for John's therapy care.
Very good point, thank you. Anybody else? Okay. Well, we appreciate very much all of you being here today. We have just oh, yes, gentlemen. Oh, okay, sorry. Didn't see the hand. Yes, sir.
I had a battery replacement back in '09 and had another one put in here in 18. I'm seeing a doctor on Monday and expecting another battery replacement. The question is, how many battery replacements can I tolerate?
For your doctor. Yeah.
Batteries and pacemaker?
Yeah. I'm sorry.
Got it. A lot of batteries, we have to clarify what we're talking about.
It was pacemaker?
Yes.
I'm sorry, sir, can you repeat the question for me, please?
I had a pacemaker put in back in '09.
Okay.
I had a battery replacement at 16 or 17, I forget which. I'm gonna see my cardiologist tomorrow, on Monday, I mean. I'm expecting he's gonna put another one in. The question is, how many battery replacements can I tolerate?
I'm not sure. it's different individually, but usually the battery replacement for pacemaker is every 10 years. That's a maximum. At healthcare, we do, if you come in with a pacemaker, we do interrogations every 3 months. That would transmit the information from healthcare to your doctor's office, and they can tell if your pacemaker is working properly and the lifespan of your pacemaker. We do, every year, we send you to a cardiologist to see as well in person. That way they can evaluate you in person. But usually to answer your question, typically it's every 10 years. It just depends on you if you want your battery replaced or not. It's something you have to talk to about your cardiologist.
I also walk 4 miles every day, 6 days a week, so that's keeping me healthy.
That's good. It's good. It's a good exercise for your heart. But as far as battery replacement, it's you and your cardiologist. Yeah.
Thank you. Anybody else? Okay. Thank you all so much. We appreciate you coming out today. And a round of applause to our team, Debbie, all of our team here at Healthcare.